Genitourinary tract acute uncomplicated cystitis and acute uncomplicated pyelonephritis. Common treatment is levofloxacin 500 mg OD and nitrofurantoin 100 mg BD for 5 days and quatrimoxazole and phosphomycin for multi-drug resistant UTI. 2 to 3 grams per oral every 2 to 3 days for 3 doses. Bacteria travel up the urethra from the rectus or anus region will cause UTI. Risk factors of females and history of UTI and sexual activity and vaginal infections, diabetes, obesity, and clinical symptoms: frequent urination, dysuria, suprapubic pain, nocturia, and hematuria, and malaise. And causative organisms: UPEC and Klebsiella, Staphylococcus saprophyticus, and Enterococcus faecalis. And risk factors: diabetes, HIV, immunosuppression, and congenital or acquired urodynamic abnormalities for pyelonephritis. And clinical symptoms for pyelonephritis: back or flank pain and fever, chills and malaise, and nausea, vomiting, and anorexia. Causative organisms and suspected virulence factors. Empirical treatment guidelines: uncomplicated UTI in women, trimethoprim 200 mg per oral BD, or if recent trimethoprim use is there, amoxiclav 625 mg TDS, or penicillin allergy, nitrofurantoin 50 mg per OD per oral QDS. Total duration 3 days. And UTI in men: trimethoprim 200 mg, penicillin allergy, nitrofurantoin, and mild UTI in pregnancy, cephalexin 500 mg per oral 7 days. Pyelonephritis IV treatment: coamoxiclav 1.2 gram TDS and single dose of gentamicin 5 mg per kg, and penicillin allergy, ciprofloxacin 500 mg per oral BD, and single dose of gentamicin 5 mg per kg IV. Urinary catheter infections: amoxicillin 1 gram TDS and gentamicin 5 mg. Here gentamicin is role is there, 5 mg per kg OD. Penicillin allergy, gentamicin 5 mg per kg once daily, and single dose of vancomycin 1 gram. Catheter total duration 7 days, and pyelonephritis total duration is more 10 to 14 days. Epidermolysis STI suspected: antibiotic treatment, ceftriaxone 500 mg single dose and doxycycline 100 mg per oral BD for 14 days, total 14 days. And genitourinary epidermolysis STI not suspected, then ciprofloxacin 500 mg BD, and if severe epidermolysis are features of bacteremia, ceftriaxone IV 1 gram and gentamicin 5 mg per kg IV OD for 3 to 5 days until fever subsides. Bacterial prostatitis STI not suspected, 500 mg BD ciprofloxacin we should give. Aminoglycosides usually given for hospital acquired UTIs and hospitalized UTIs, gentamicin, amikacin. And when we are giving aminoglycoside, we should monitor urine output and renal function and get urine culture. And piptas also effective, and usually treatment for longer days for 14 days. Consider removing catheter, if not possible, changing the catheter if it has been placed for more than 7 days, and do not delay antibiotic treatment. Send urine sample for culture and susceptibility testing. Antibiotic, nitrofurantoin and trimethoprim. Tubes and punctures: endocarditis, so valve abnormality, prosthetic valve and native valve damage, and source of bacteria include IV abusers, dental procedures, skin infections, open wounds, and surgical procedures. Bacteria and bloodstream: bacteria adhere to thrombi and proliferate, endocarditis and vegetations. Endocarditis vehicle borne diseases. Causes include Pseudomonas, Klebsiella, MRSA. Drugs include piptas, meropenem, clindamycin, vancomycin. Anti-pseudomonal include piptas and ceftazidime or cefepime, imipenem. And aminoglycosides include tobramycin and gentamicin. Fluoroquinolones include ciprofloxacin or levofloxacin. Empirical treatment guideline: infective endocarditis, amoxicillin 2 gram IV 4 hourly, and gentamicin 1 mg per kg ideal body weight IV BD. It is preferable to wait for blood results before commencing treatment. And infective endocarditis, acute presentation or indolent presentation with penicillin allergy with no risk factors for multi-drug resistance. Vancomycin IV 15 to 20 mg per kg IV 8 to 12 hours every, and gentamicin 1 mg per kg IV BD. If GEGFR is less than 45, use ciprofloxacin 750 mg per oral BD or 400 mg IV BD 12 hourly instead of gentamicin. In case of sepsis, community acquired sepsis of unknown origin, meningitis not suspected, coamoxiclav 1.2 TDS and gentamicin 5 mg per kg OD, and metronidazole 500 mg TDS if anaerobic infection is suspected. If penicillin allergy is there, teicoplanin and gentamicin and metronidazole. Adult CNS infection, suspected bacterial meningitis, ceftriaxone 4 gram OD, add amoxicillin 2 gram 4 hourly, patient more than 50 years and if immunocompromised patients. In case of infection, HSV suspected encephalopathy, acyclovir 10 milligram per kg TDS and dose reduction required if eGFR is less than 50. Treat for 14 to 21 days, and CSF should be sent for viral PCR. Sepsis has capillary leakage due to endothelial dysfunction and disseminated intravascular coagulation due to coagulopathy and cellular dysfunction, catabolic state, reduced cellular energy consumption, and left ventricular dilatation is due to cardiovascular dysfunction, and it will cause hypotension and multi-organ failure. MRSA antibiotics are vancomycin 500 milligram and teicoplanin 400 milligram and linezolid and clindamycin. Vancomycin, teicoplanin, clindamycin and linezolid. Factors what we should consider before giving antibiotic: any history of allergy, is it proper spectrum for the microorganisms, what is the route of administration, what are the factors, and any drug instructions, and any serious toxicity, and does it need monitoring, example aminoglycoside, vancomycin, streptomycin. Bactericidal antibiotics are beta-lactams, aminoglycosides, and glycopeptide, vancomycin, metronidazole, and quinolones, and rifampicin. Bacteriostatic are macrolides, sulfonamide, chloramphenicol, and tetracyclines, and oxazolidones, and lincomycin. So if you give in last 90 days any bactericidal or static antibiotic, next time you should give only bactericidal antibiotic. Thank you.